Welcome to a brand new deep dive. We are thrilled to have you here with us today. You, the listener, pulling up a chair as the third person in the room, are in for something really profound today.
Absolutely.
Because our mission today is to map out a transition that every single human being will eventually undergo, yet very few actually understand from a structural, clinical, and legal perspective. We are charting the fascinating, highly structured transition from biological end to legal scrutiny.
And we are doing this by strictly following the roadmap laid out in Chapter 3 of Simpson's Forensic Medicine.
Right, the medical legal aspects of death.
Let's set the tone right from the outset. We are approaching this with the absolute clinical precision that the subject demands. Whether you are, say, a medical student furiously prepping for your finals,
Or a junior doctor who is secretly terrified of writing your very first death certificate at 3 in the morning.
Exactly. Or even a senior clinician brushing up on your forensic foundations, our goal today is to build crystal clear conceptual frameworks for you. You won't find any sensationalism here.
None at all.
What you will find is professional neutrality, deep clinical reasoning, and essential pattern recognition. Because understanding death legally and medically requires a highly disciplined, objective mind.
That is the perfect framing. Because medically and scientifically, death is not, it's not a singular event. It's not a moment you can simply point to on a clock and say, that is when it happened.
No, it's a process.
It is a biological process. And today's deep dive is going to decode that entire process. We are going to translate cellular cessation into somatic legal definitions.
We'll explore what actually happens when consciousness is lost and analyze the incredibly complex ethics of organ transplantation.
And finally, we will master the Medical Certificate of Cause of Death, the MCCD. So let's jump right into the core biological reality. The textbook establishes that only organisms that have experienced life can die. Death represents the cessation of life in a previously living organism. But as I was reading the source material, it struck me that different tissues and organs in the human body shut down at radically different rates. Can you walk me through why that differential rate exists?
Yeah, that differential rate of cellular death is precisely what creates so much debate, ethical, cultural, religious, and moral debate about when death actually occurs. To navigate this, forensic medicine relies on a critical conceptual framework.
Okay.
We must differentiate the death of a single cell, which we call cellular death, from the cessation of the integrated functioning of the individual, which we term somatic death.
Two very different things.
They are entirely separate biological and legal phenomena, and conflating the two is where a lot of confusion begins.
Let's look at cellular death first, because that seems like the absolute microscopic baseline. What does cellular death actually look like biologically?
At its core, the mechanism is the cessation of respiration. Now, in this context, we don't mean breathing air into the lungs.
Right, not the chest rising and falling.
Yeah.
Exactly. We mean respiration at the cellular level, the utilization of oxygen to create energy. When a cell can no longer utilize oxygen, its normal metabolic activity stops. Without that energy, the cell cannot maintain its internal structures.
And then what happens?
This is very quickly followed by a process called autolysis. Essentially, the lysosomes inside the cell, which contain digestive enzymes, break open. The cell begins to digest itself from the inside out. Following autolysis, environmental bacteria move in, and we see full-blown decay.
So the cell essentially self-destructs. And the text notes that from a purely forensic standpoint, complete body decay is the only truly unchallengeable absolute evidence of true death.
That is the grim reality of forensic pathology. Short of complete decay, we are dealing with a staggered biological shutdown, unless you are dealing with a synchronous event.
Like explosion.
Right, like a complete instantaneous vaporization of all cells following an explosion or stepping into a blast furnace. Short of that, the trillions of cells in the human body do not all die simultaneously.
Okay, let's unpack this, because the staggered timelines of cellular death are genuinely mind-boggling. I think the average person assumes that when the heart stops and the doctor calls the time of death, everything in the body just immediately powers down.
It's a common misconception.
But the text states that skin and bone can remain metabolically active and essentially living for many hours. In fact, cells from these tissues can be successfully cultured in a laboratory days after the person has died. Days. How is that physiologically possible?
It comes down to the metabolic demands of specific tissues. Skin cells, fibroblasts, and bone cells have relatively low metabolic rates. They are built to be resilient, to withstand environmental stress, and they don't require a massive, continuous influx of oxygen to survive minute to minute.
So they just keep going on reserves.
Therefore, they can survive on whatever residual oxygen and nutrients are left in the surrounding extracellular fluid long after the heart stops pumping fresh blood.
That resilience is fascinating. But I want to pivot to a detail that absolutely blew my mind, something that feels like a massive trap for a junior forensic pathologist. The text mentions the behavior of white blood cells post-mortem.
Yes, the motility of leukocytes. This is a crucial clinical anchor for anyone studying forensic medicine. White blood cells are capable of independent amoeboid movement for up to 12 hours after cardiac arrest.
Let's put the listener in the shoes of a junior doctor or a forensic pathology trainee for a second. Imagine you are in the lab looking at tissue slides from a victim who was found dead. The body was discovered 8 hours ago.
Okay.
You look under the microscope at a laceration on the victim's arm, and you see white blood cells actively mobilizing, moving into the wound tissue. The natural assumption, the seemingly logical deduction, would be that the person was attacked, they suffered the wound, their immune system reacted, and then they died. You would assume you were looking at a vital reaction, proving the injury happened during life.
And if you made that assumption on the witness stand, a good defense attorney would tear your testimony to shreds.
Wow. Because, as the textbook emphasizes, if white blood cells can still move for 12 hours post-mortem, microscopic identification of a vital reaction based solely on cellular infiltration becomes highly unreliable.
Because they could just be reacting after the fact.
Exactly. You cannot definitively say whether those immune cells mobilized in the minutes before the heart stopped or in the hours after. It is a classic example of why forensic medicine requires immense discipline. You must understand cellular timelines.
And on the complete opposite end of the spectrum from those rugged, resilient white blood cells, you have the cortical neurons in the brain. The text points out how incredibly fragile they are.
The brain's cortex has an almost zero tolerance for hypoxia. Without a continuous supply of oxygenated blood, a cortical neuron will die in a mere 3 to 7 minutes.
3 to 7 minutes, that is nothing. The brain is an absolute energy hog. It consumes about 20% of the body's total oxygen supply, despite being a fraction of its weight. When the oxygen stops, the neurons deplete their ATP reserves almost instantly, the ion channels fail, and irreversible cellular death cascades rapidly.
So you have this massive variance. 3 minutes the brain cortex, 12 hours for white blood cells, days for skin and bone. It makes me think of the body as a massive, sprawling city.
That's a good way to look at it.
When a catastrophic apocalyptic crisis hits, the city doesn't just instantly go dark with the flick of a single light switch.
Yeah.
The power grid shuts down neighborhood by neighborhood.
Right.
The financial district, the highly sensitive cortical neurons that run the whole operation, crashes almost instantly. The servers fry, the data is gone, the management is wiped out in minutes. But the localized backup generators in the suburbs, the skin, the bone, the white blood cells acting like emergency responders, keep humming along for hours or even days, completely unaware that the central government has already fallen.
That is an incredibly helpful metaphor for conceptualizing the staggered nature of cellular death. The body dies cell by cell. The complete process takes many hours, even though this microscopic reality won't be evident to the grieving family or the observers in the hospital room.
It's all hidden under the surface.
And that brings us perfectly to the second aspect of our framework. If cellular death is the backup generators slowly failing, somatic death is the fall of the central government.
So let's establish the legal and biological lines of somatic death. How does the textbook define it?
Somatic death is defined as the irreversible state where an individual will never again communicate or deliberately interact with the environment. The individual is irreversibly unconscious and unaware of both the world and their own existence.
I really want to emphasize that keyword for you, the listener. Irreversible. That is the absolute linchpin of the whole concept. Because a lack of communication and interaction can happen in a variety of non-fatal states. It happens in deep sleep, under heavy surgical anesthesia, under the extreme influence of depressant drugs or alcohol, or during a temporary coma following a traumatic head injury. But somatic death demands absolute irreversibility. There is no waking up.
And historically, diagnosing somatic death was relatively straightforward. You checked for a pulse, you checked for breathing. If both were gone and didn't come back within a few minutes, the person was somatically dead.
Very clear cut.
But if we connect this to the bigger picture, we have to look at how modern technology has fundamentally disrupted the natural process of dying. Advances in resuscitation techniques over recent decades, specifically mechanical ventilation and pharmacological cardiovascular support, have completely uncoupled respiratory arrest from cardiac arrest.
Uncoupled them. That is a massive shift in human biology. Before the mid-20th century, that uncoupling simply did not exist.
It did not. Historically, the biological cascade was direct and inescapable. If a patient suffered brainstem death, perhaps from a massive stroke or severe head trauma, they would inevitably and quickly suffer respiratory arrest.
Because the brainstem controls breathing.
Yes. The brainstem houses the respiratory center, so if it dies, you stop breathing. Because you stop breathing, myocardial hypoxia occurs. The heart muscle is starved of oxygen, and because of that hypoxia, cardiac arrest follows within minutes. Brain death equaled respiratory death, which equaled cardiac death. It was a tight, rapid sequence.
But today, artificial ventilation interrupts that sequence entirely. You can have a patient whose brainstem is completely irreversibly destroyed. They have no natural drive to breathe, but a machine is physically forcing oxygenated air into their lungs.
And that oxygen enters the blood.
Right, and the heart, which has its own intrinsic electrical pacemaker nodes, continues to beat because it is still receiving oxygen. The machine prevents the myocardial hypoxia and therefore prevents the cardiac arrest. The central government of the city is gone, but the pumps are still running because we plug them into a wall outlet.
Exactly. And because of these machines, we now rely on incredibly strict diagnostic criteria to legally and medically declare death. What is fascinating from a medical legal standpoint is that in the United Kingdom, there is actually no statutory legislated definition of death. There is no single act of parliament that says death is defined as X.
That seems incredibly risky. If there's no law, how do doctors know what standard to apply?
Instead of rigid legislation, which can quickly become outdated by medical advances, the legal and medical systems rely on clinical consensus frameworks that have been rigorously tested and adopted by the courts. Specifically, we rely on the criteria first laid out by the 1976 Conference of Medical Royal Colleges and the updated 2008 Academy of Medical Royal Colleges Code of Practice.
Walk me through what a doctor actually does when applying these frameworks. Let's start with the more common scenario. A patient's heart and breathing have stopped. They are not on a ventilator. This is covered under the criteria for diagnosing death following cardiorespiratory arrest. What is the clinical protocol?
The cardinal rule here is the 5-minute observation period. The person responsible for confirming death must continuously observe the individual for a minimum of 5 minutes. They are ensuring there is an absolute absence of a central pulse on palpation, feeling for the carotid artery in the neck, for instance, and an absence of heart sounds on auscultation with a stethoscope.
Why specifically 5 minutes? Is there a physiological reason for that time frame?
Yes. 5 minutes is generally accepted as the absolute limit beyond which the cortical neurons we discussed earlier suffer irreversible anoxic damage. Furthermore, it accounts for a very rare but documented phenomenon known as autoresuscitation, or the Lazarus syndrome, where a heart can spontaneously regain a rhythm shortly after CPR is terminated.
So it's a safety buffer.
Waiting a full 5 minutes without any intervention ensures that any cessation of cardiac activity is truly irreversible.
And during those 5 minutes, the doctor isn't just standing there staring at a watch. They are actively performing multimodal checks. They are shining a light into the eyes to confirm the absence of pupillary responses. They are lightly touching the surface of the eye to confirm the absence of corneal reflexes. They are applying supraorbital pressure, pressing hard on the nerve right above the eyebrow to check for any motor response to pain.
And in a modern hospital setting, you don't just rely on your physical senses. You use the supplementary technological evidence available to you. You want to see continuous asystole, a flat line, on the ECG display for that entire 5 minutes. You might use echocardiography to look for the complete absence of contractile activity in the heart muscle, or check for the absence of pulsatile flow using direct intra-arterial pressure monitoring. The goal is to build an objective, irrefutable clinical picture.
Now that's for cardiorespiratory arrest. That is the traditional pathway. But what about the second scenario, the one created by our modern technology?
Yeah.
How do doctors diagnose death when the ventilator is keeping the heart beating and the chest rising and falling?
This is diagnosing death following the irreversible cessation of brainstem function. The requirements here are incredibly stringent because the physical appearance of the patient, pink skin, a beating heart, a rising chest, directly contradicts the reality of death. First, you need 2 medical practitioners to perform the testing together. Both must have been registered with the Medical Council for more than 5 years, ensuring they have significant clinical experience, and at least one of them must be a consultant.
And they are essentially performing a battery of tests to prove that the brainstem, the most primitive and fundamental part of the brain, is completely offline.
Correct. They are testing the cranial nerve reflexes, which all route through the brainstem. They check the pupils. They must be fixed and unresponsive to intense light. The corneal reflex must be totally absent. They test the oculovestibular reflexes, often called caloric testing.
What does that involve?
They introduce ice-cold water directly into the external ear canals. In a living, intact brainstem, this severe temperature change triggers a distinct eye movement. In brainstem death, the eyes remain perfectly still. There must be no motor response in the cranial nerve distribution to any severe somatic stimulation. They will place a suction catheter deep into the trachea to prove there is no cough reflex. They will stimulate the posterior pharynx to prove there is no gag response.
It sounds intensely thorough, but the absolute critical hurdle, as I understand it, is the apnoea test. Can you explain the visceral reality of what happens during that specific test?
The apnoea test is the ultimate proof of brainstem failure. Imagine you are in the intensive care unit. The machines are beeping rhythmically, the ventilator is pushing air in and out, the doctors literally disconnect the patient from the ventilator. The room goes quiet, the artificial breathing stops. The doctors stand there watching the patient's chest, waiting to see if there is any spontaneous biological attempt to draw a breath.
But they don't just wait and guess, right? They're measuring something highly specific in the blood.
Exactly. As the patient lies there disconnected, carbon dioxide is naturally building up in their bloodstream because they aren't exhaling it. The doctors take arterial blood gas samples to precisely measure the partial pressure of carbon dioxide, the KSO2. They are waiting for it to increase by more than 0.5 kilopascals above the starting level.
Why carbon dioxide and not oxygen?
Because a rising level of carbon dioxide in the blood is the body's ultimate, most powerful chemical panic button. In a living person, when CO2 spikes, chemoreceptors scream at the respiratory center in the brainstem, forcing you to take a breath. It is an overwhelming physiological drive.
So there's no response to that.
Right. During the apnoea test, if the blood test proved the CO2 has crossed that critical threshold and the brainstem still does absolutely nothing, no gasp, no twitch of the diaphragm, it proves the respiratory center is completely, irreversibly dead.
But the textbook outlines a major caveat. Before a doctor can even legally begin these brainstem tests, they must satisfy a set of absolute clinical exclusions. They have to prove that the patient's unresponsiveness isn't just an incredibly convincing mimic of death.
This is a crucial medico-legal safeguard. You must definitively prove the coma isn't caused by a reversible factor. You must exclude hypothermia. You must exclude depressant drugs like massive overdoses of narcotics, barbiturates, or tranquilizers. You must exclude profound metabolic and endocrine disturbances, such as extreme hypoglycemia or severe electrolyte imbalances. If any of these potentially reversible factors are present, you cannot legally diagnose brainstem death.
Because all of those things can perfectly mimic a dead brainstem. Let's take hypothermia as an example. If someone falls into an icy river and is pulled out an hour later, their core temperature might be drastically low. A deeply hypothermic patient might have fixed, dilated pupils. They might have absolutely no gag reflex, no cough reflex, no response to pain. Their heart rate might be so slow and faint it's undetectable. They look dead, they test dead. But they aren't dead, they are just profoundly cold. The low temperature has simply suspended their cellular metabolism.
It is the oldest and truest medical adage in emergency medicine. You aren't dead until you're warm and dead. You must actively rewarm the patient to a normal physiological temperature before you can even assess neurological function. Barbiturate overdoses can do the same thing, completely suppressing brainstem reflexes. This clinical rigor ensures that somatic death is diagnosed only when the loss of function is truly biologically irreversible.
So we have a clear, highly structured protocol for determining when someone has crossed the line into somatic death. But what happens when a patient suffers a catastrophic injury? They're rushed to the hospital, they're resuscitated, and they fall into a gray area. They don't meet the criteria for brainstem death, but they don't wake up either. This brings us to a deeply sensitive and ethically fraught area: prolonged disorders of consciousness, or PDOC.
Because of the advanced resuscitation techniques we just discussed, we have created a spectrum of survival that simply didn't exist a century ago. When a patient suffers severe brain injury, whether from trauma or from hypoxia following a cardiac arrest, the outcomes vary wildly. Some patients eventually recover spontaneous breathing and full consciousness. Others might never regain consciousness, but their brainstem recovers enough that they regain the ability to breathe on their own without a ventilator. and some regain neither, requiring permanent artificial ventilation to stay biologically alive.
To manage this clinically, ethically, and legally, the medical field uses a specific differentiation framework. We need to distinguish between three distinct states: coma, vegetative state, and minimally conscious state. Let's break these down because the terminology is often misused by the public. Let's start with coma.
To understand these states, you have to separate two fundamental components of consciousness: wakefulness and awareness. Wakefulness is the basic arousal mechanism driven largely by the brainstem and the reticular activating system. Awareness is the higher-level cognitive function, experiencing the environment, having thoughts, processing language, which is driven by the cerebral cortex. A coma is characterized by an absence of both. There is absent wakefulness and absent awareness.
So the patient's eyes are closed and nobody is home.
Clinically, it is defined as a state of unarousable unresponsiveness lasting more than 6 hours. The patient cannot be awakened by any means. They fail to respond normally to intense pain, light, or sound, and critically, they lack a normal sleep-wake cycle. The brain is essentially in a deep, continuous state of shutdown.
Okay, so coma is no wakefulness, no awareness. But then we have the vegetative state, or VS, and this state sounds absolutely agonizing for the families involved. How is a vegetative state defined?
A vegetative state is defined as wakefulness with absent awareness. The brainstem has recovered enough to handle basic arousal, but the cortex remains severely damaged or offline. This is deeply distressing for families because the patient looks, in many ways, like they are waking up. They have preserved capacity for spontaneous or stimulus-induced arousal. Their eyes might open. They develop distinct sleep-wake cycles, meaning they appear to sleep at night and wake up during the day. They might exhibit reflexive behaviors, they might swallow, or their hand might reflexively close around your finger if you place it in their palm.
And a desperate family member will feel that hand squeeze and immediately assume they are in there, they are communicating with me.
Exactly. It is a very human reaction. But neurologically, it is a primitive spinal or brainstem reflex. In a true vegetative state, there is a complete, absolute absence of behavioral evidence for self-awareness or environmental awareness. There is no purposeful tracking with the eyes, no command following, no communication. The lights are on, the engine is idling, but there is no driver behind the wheel. They are awake, but they are completely unaware.
And finally, we have the minimally conscious state, or MCS. Where does this fall on the spectrum?
The minimally conscious state is defined as wakefulness with minimal awareness. The cortex has retained or recovered a tiny fraction of its function. The key diagnostic characteristic of MCS is inconsistent but reproducible responses that go above mere reflexive behavior.
What does that look like in a hospital bed?
A patient in an MCS might occasionally track a moving mirror with their eyes, demonstrating visual pursuit. They might appropriately reach for a cup when offered, rather than just reflexively grasping whatever touches their hand. They might occasionally vocalize in response to a specific person. The responses are often fluctuating and exhausting for the patient, but they indicate some minimal, actual degree of interaction with their surroundings.
So just to recap the framework for the listener, coma is no wakefulness, no awareness. Vegetative state is wakefulness but no awareness. Minimally conscious state is wakefulness with minimal, inconsistent awareness. It's a ladder of consciousness. But the prognosis, the prediction of the future, is where the medico-legal aspect really sharpens into a razor's edge. If someone is in a vegetative state, how long do doctors wait before they declare that state to be permanent?
The timelines differ depending on the guidelines you follow, which honestly reflects the inherent medical uncertainty of brain injuries. It is not an exact science. The U.S. Academy of Neurology guidelines state that a vegetative state may be judged permanent at 12 months if the underlying cause was a traumatic brain injury, like a severe car crash. However, they reduce that timeline to just 3 months if it was a non-traumatic brain injury, such as prolonged hypoxia from a cardiac arrest.
That is a massive difference. Why do they wait a full year for a traumatic injury but give up hope after just 3 months for an oxygen deprivation injury?
It comes down to the mechanism of cellular damage. A physical trauma to the brain, like a severe blow or a penetrating wound, damages specific areas but often leaves the overall microscopic architecture of the brain somewhat intact. This intact scaffolding allows for potential, albeit incredibly slow, neuroplastic recovery. The brain might find workarounds. But hypoxia, a total lack of oxygen, causes diffuse, global cellular death across the entire brain simultaneously. The fundamental architecture itself is destroyed. Meaningful recovery from global hypoxic necrosis is much faster to rule out.
And the UK guidelines have their own variation, right?
Yes, the UK Royal College of Physicians guidelines are slightly more cautious regarding hypoxic injuries, recommending a 6-month wait for non-traumatic brain injuries rather than the US's 3 months. But I must emphasize something crucial for any medical professional listening. These timelines are probabilities, not absolute certainties. The term permanent here refers strictly to prognosis. It identifies the point in time after which recovery of consciousness is deemed highly improbable, but not impossible.
And it is precisely at that point, when recovery is declared highly improbable, where the most agonizing end-of-life decisions come into play. When does the withdrawal of hydration and assisted nutrition become in the best interest of a patient who will never wake up? This leads us directly to the landmark medical legal cases that have shaped this entire field in the UK. The first major one every clinician needs to know is Airedale NHS Trust v. Bland from 1993.
To understand the legal weight of this case, you have to understand the tragedy behind it. Tony Bland was a young man who was caught in the crush during the Hillsborough football stadium disaster in 1989. 96 people eventually died as a result of that horrific crowd crash. Tony survived the initial event, but he suffered severe hypoxic brain damage because his chest was compressed for so long that his brain was starved of oxygen.
He fell into a persistent vegetative state, and he remained in that state, kept alive by feeding tubes, for over 3 years.
Yes. His parents and his treating doctors eventually came to the heartbreaking but unified conclusion that there was absolutely no hope of recovery, and that continuing to prolong his biological life through artificial nutrition and hydration was providing him with no benefit. They applied to the courts for permission to withdraw his feeding tubes.
Which was uncharted legal territory at the time. To intentionally withdraw food and water knowing it would result in death felt dangerously close to active euthanasia for many in the legal system.
It was a massive legal and ethical battle that went all the way to the House of Lords. Ultimately, the court ruled that artificial feeding and hydration constituted medical treatment. And because the medical treatment was deemed futile, it could not cure him or improve his condition, it was no longer in Tony Bland's best interest to continue it. The Bland case established the legal precedent allowing the withdrawal of life-sustaining treatment in patients in a permanent vegetative state.
But while Bland set the precedent, it also created an immense bureaucratic burden. For decades after the Bland ruling, every single decision to withdraw life support for a permanent VS patient in the UK required a formal application to the Court of Protection.
It was incredibly demanding, even if the entire medical team and the entire family were in complete harmonious agreement that the patient would not want to be kept alive. The hospital trust still had to hire lawyers, gather expert testimonies, and drag the grieving family through a lengthy, expensive, and emotionally exhausting court process just to get legal permission to stop treatment.
But that landscape fundamentally changed very recently with the 2018 UK Supreme Court judgment in the case of an NHS Trust v. Y. Tell us about Mr. Y.
This raises an important question regarding legal bureaucracy. Mr. Y was a 52-year-old financial analyst. He was a very active man who suffered a sudden cardiac arrest and subsequently fell into a prolonged disorder of consciousness. After extensive assessment, all the medical experts agreed it was highly improbable he would ever reemerge into consciousness. Furthermore, they noted that even if he did miraculously regain a glimmer of awareness, he would be trapped in a body with profound, permanent disabilities. Both his treating doctors and his deeply devoted family agreed that continuing life support was absolutely not what he would have wanted, and it was not in his best interest.
Under the old Bland rules, they would have had to endure months of court hearings. But the hospital trust challenged that necessity, and the Supreme Court made a landmark ruling. They stated that in these specific circumstances where the clinical medical team and the relatives are in complete, unquestioned agreement that withdrawal is in the patient's best interest, legal permission from the Court of Protection is no longer required.
That ruling was a massive reduction in legal bureaucracy at the end of life. It recognized that the court's role is to resolve disputes, not to medically manage clear consensus. It allows families to find peace and closure without being dragged through a public court battle, while still maintaining the absolute requirement for strict clinical consensus and adherence to professional guidelines.
It is a profound shift back toward trusting clinical expertise and familial love. Now, we've established the legal and biological lines of death and the ethical struggles of the gray areas. But the moment that legal line of death is crossed, a completely different, incredibly time-sensitive medical operation often begins. This brings us to tissue and organ transplantation. This is an area where medicine, law, ethics, and religion intersect more intensely than almost anywhere else in healthcare.
The entire transplantation framework relies entirely on these cultural and legal boundaries. As a doctor, your technical ability to transplant an organ is secondary to the legal and ethical permission to do so. The source text points out that while very few major religions expressly forbid transplantation in all forms, there are strict exceptions you must navigate. Jehovah's Witnesses, for instance, fundamentally reject the transfusion of donated blood or blood products based on their religious tenets, though they may accept certain solid organ transplants if managed bloodlessly. Your medical capability is always bounded by the patient's beliefs and the law.
Let's look at the pattern recognition for the different categories of transplantation, because the terminology is specific.
The first category is homologous transplantation, often referred to as autografts. This is moving tissue between different sites on the same individual's body. The classic example is a burn victim, where a surgeon takes a thin layer of healthy skin from the patient's thigh and grafts it over the burned area on their chest. Or harvesting bone chips from a patient's own pelvis to pack into a complex spinal fusion surgery. Because it is the patient's own tissue, there is zero risk of immunological rejection.
Then we step up to live donation. This is where tissue or an organ is taken from a living donor to be implanted into a compatible recipient. Blood transfusions and bone marrow transplants are the most common examples. But live solid organ donation is also highly prevalent, specifically kidneys, since humans are born with a paired set and can live a perfectly normal life with just one.
But live donation requires immense, formalized oversight to protect the healthy donor. The source notes the Transplantation Society's consensus statement, which was developed involving experts from over 40 countries. They mandate rigorous psychological and physiological selection procedures for live donors. You have to ensure the donor isn't being coerced, that they fully understand the risks, and that their remaining kidney is healthy enough to sustain them. Furthermore, they demand long-term follow-up to track complications. A hospital cannot simply take a kidney from a living person, transplant it, and send the donor on their way. The transplant center is legally and ethically responsible for tracking that donor's ongoing health for years.
The third category, and globally the major source of all solid organs, is cadaveric donation. This is harvesting organs from a patient who has been declared legally dead, usually via the brainstem criteria we discussed earlier, allowing their organs to be maintained on ventilators until the surgical retrieval team arrives. Talk to me about the sheer logistical urgency of cadaveric donation. The text mentions warm ischemic time.
Warm ischemic time is the absolute enemy of a transplant surgeon. It refers to the time an organ spends at normal body temperature without a continuous supply of oxygenated blood. As soon as the blood flow stops, the cellular death clocks we talked about at the very beginning of the deep dive start ticking loudly. The goal is to minimize this time by rapidly cooling the organs with specialized preservation fluids.
And different organs have different tolerances.
That's drastically different. Kidneys are relatively robust. They can survive up to 30 minutes of warm ischemia after the complete cessation of cardiac activity before suffering irreversible damage. That gives surgeons a small window to retrieve them even after a cardiac death. Hearts and lungs, however, are incredibly sensitive. They have a much narrower window and generally require the patient to be a brainstem dead donor, where the organs are perfused right up until the moment they are cooled and removed.
And then we have the more futuristic categories, xenografts and cloning. When I hear cloning, I immediately think of Dolly the sheep back in 1996, the first mammal cloned from an adult somatic cell. While whole animal cloning for the purpose of harvesting human-compatible organs is still largely theoretical and ethically restricted, xenotransplantation, moving tissue from one species to another, is a very real, current clinical practice.
We use porcine, or pig, heart valves routinely to replace damaged human valves. In advanced cancer research, oncologists heavily rely on patient-derived xenograft, or PDX, models. This involves taking a biopsy of a human patient-specific tumor and implanting it into an immunocompromised mouse. The human tumor grows in the mouse, and researchers can test various chemotherapy drugs on the mouse to see which ones effectively kill that specific patient's cancer cells.
The science is remarkable, but the risks associated with moving living tissue between species are profound.
When discussing live xenografts, like attempting to transplant a whole pig heart into a human, the medical community must cautiously manage severe, almost insurmountable challenges. First is the extreme difficulty of tissue cross-matching. The human immune system is aggressively designed to destroy foreign tissue, and a different species triggers the most violent rejection response imaginable. But the second, and arguably more terrifying risk from a public health perspective, is the potential for cross-species viral transfer.
meaning a virus that normally only infects pigs could hitch a ride on the transplanted organ, mutate inside the human host who is on heavy immunosuppressant drugs to prevent rejection, and potentially spark a new zoonotic pandemic.
Exactly. Scientists worry specifically about PRVs, porcine endogenous retroviruses. These are ancient viral sequences permanently embedded in pig DNA. This is why animals intended for experimental xenotransplantation are not just raised on a farm. They are bred in meticulously clean, biosecure, isolated laboratory conditions to minimize pathogen exposure.
Let's bring it back to the logistics of human donation and look at the legal consent frameworks. This is a crucial area of legal differentiation in the UK that every medical professional needs to understand, as the laws are changing rapidly. We have two contrasting systems: opt-in versus opt-out.
Historically, in England, the traditional opt-in system has applied. This meant that an individual had to actively register their desire to be a donor, for instance, by signing the NHS organ donation register or carrying a donor card. Alternatively, their families had to explicitly agree to the donation after their death. The burden was on the medical team to ensure proactive, explicit permission was granted before any harvesting could occur.
I know England's rules have evolved recently, but hasn't the legal landscape around consent been shifting drastically in other parts of the UK for over a decade, specifically in Wales?
It has, massively. Wales flipped the script entirely. The Human Transplantation Wales Act 2013 introduced an opt-out system, which is formally known as a system of presumed consent. Under this law, it permits hospitals to presume that people aged 18 or over who have been legally resident in Wales for more than 12 months want to donate their organs when they die unless they have specifically objected in writing and placed themselves on an opt-out register.
It changes the default position of society from do not touch unless permitted to we assume you want to help unless you tell us otherwise. But regardless of whether a country uses an opt-in or an opt-out framework, there is a hard legal stop regarding coronial jurisdiction. This is a vital medical legal point for every junior doctor to memorize.
If a death occurs under circumstances that legally require a formal autopsy, perhaps it was a sudden death, a violent death, or an unexplained accident, the coroner in England and Wales, or the procurator fiscal in Scotland, takes immediate legal possession of the body. The clinical doctors lose their authority. In these cases, the coroner must give explicit permission before any organs or tissue can be harvested by the transplant team.
Why does the coroner have the final say?
Because the organ itself might be the critical piece of forensic evidence needed to determine the precise cause or manner of death. If a person dies in a car crash, and the coroner suspects they might have had a massive heart attack that caused the crash, they need to examine the intact heart. They cannot allow a transplant surgeon to remove it.
But realistically, the textbook notes that the coroner rarely objects to donation, right?
Generally, yes, because practically speaking, heavily damaged or diseased organs aren't going to be accepted for transplantation anyway. The transplant team only wants pristine organs. Often, a practical solution is reached to clear the legal hurdle. The coroner will instruct the forensic pathologist to actually be present in the operating room while the transplant surgeons retrieve the organs. This allows the pathologist to inspect the chest and abdominal cavities, photograph the internal organs in situ, and document any trauma firsthand without preventing the life-saving donation.
That's a great example of medicine and law working collaboratively. Now, while cadaveric donation in countries like the UK is highly regulated and incredibly transparent, the immense global demand for organs, specifically live donation, introduces profound vulnerabilities.
It is a basic, tragic economic reality. There are millions of desperate people dying of organ failure and a severe shortage of willing donors. This imbalance has created a horrific, highly lucrative black market.
Here's where it gets really interesting and a bit dark, but it is a critical component of forensic medicine's global scope. As hosts, we are going to strictly and neutrally report the findings laid out in our source text regarding organ trafficking. We are not taking a political stance, simply conveying the findings. The textbook details a practice known as forced organ harvesting, which it identifies as the most extreme form of organ trafficking.
The forensic text cites the extensive findings of the 2019 China Tribunal report. After hearing vast amounts of testimony and reviewing medical data, the independent report concluded that forced organ harvesting has been committed for years throughout China on a significant industrial scale. The tribunal stated that Falun Gong practitioners have been one and probably the main source of this involuntary organ supply.
The report also notes that the concerted persecution, mass internment, and enforced medical testing of Uyghur populations in Xinjiang is a more recent development. Therefore, the tribunal suggested that evidence of forced harvesting specifically from this group may emerge as investigations continue. The tribunal bluntly stated it had no evidence that the vast infrastructure associated with China's transplantation industry has been dismantled, concluding that forced organ harvesting continues today.
Furthermore, the textbook mentions broader global allegations that in some countries, prisoners of conscience, individuals imprisoned for their political or religious beliefs rather than violent crimes, are executed specifically for their organs. These organs are then allocated to wealthy domestic citizens or international transplant tourists who travel abroad and pay massive sums of money to bypass the waiting lists in their home countries.
In response to this profound global threat, the World Health Assembly passed a specific resolution urging all member states to actively protect their poorest and most vulnerable groups from transplant tourism and the illicit sale of tissue and organs. Again, we are merely conveying the findings documented in the provided medical text, but it underscores the massive ethical and human rights responsibilities that govern the field of transplantation.
It is a sobering reminder that medicine does not exist in a clinical vacuum. It is deeply intertwined with human rights, economics, and international law. A doctor's responsibility doesn't end at the bedside. And that realization brings us to our final major topic, which is the ultimate documentation of that responsibility, cause of death determination and certification, specifically the medical certificate of cause of death, or the MCCD.
So, after the biology has failed, after the legal definitions are met, and after transplantation is considered, what does this all mean when you, the doctor, finally sit down with a pen and a blank certificate? It feels like just filing paperwork, but it's not.
Yeah.
When deciding what to ascribe an individual's death to, you are fundamentally making a profound philosophical and legal judgment about causation.
Legally, the law of causation requires that the cause you identify is something that is substantial and significant. Furthermore, it must strictly meet what lawyers call the but-for test.
The but-for test. I always think of this like an incredibly high-stakes chain of dominoes. The law isn't asking about the gentle breeze in the room that might have eventually blown the domino over in a few weeks. It's asking, but for you pushing the very first domino today, would the last one have fallen? The outcome, death, would not have occurred but for the occurrence of this specific illness, disease, or traumatic action. If the patient was so critically ill that they would have died at that exact same moment anyway, then the secondary factor in question is not the legal cause of death.
That is an excellent analogy. You are looking for the hand that pushed the first domino. And to capture that chain of events accurately, the death certificate has a very specific architecture. Let's look at the anatomy of the certificate. This framework was defined by the World Health Organization way back in 1979, and it serves as an international standard to this day. It is divided into two main parts. Part 1 is the direct chronological chain of events leading directly to death. It usually has 3 lines, 1A, 1B, and 1C.
And the logic flows upward. Line 1A is the immediate cause, which was caused by line 1B, which was caused by line 1C.
Here is the most critical rule for medical students to drill into their minds. The condition lowest on the Part I list is the most important statistically and legally. It is the underlying primary pathological condition that initiated the entire chain of events. It is the first domino. Let me give you a clinical example. You might write 1A, congestive cardiac failure, due to 1B, essential hypertension. The hypertension is the underlying cause. It is the disease that set everything in motion.
Let me try another example to make sure I have the pattern recognition down. Let's say a patient has a congenital defect in a blood vessel in their brain. It ruptures, causing bleeding, which causes a coma, which leads to death. I would write 1A, coma, due to 1B, subarachnoid hemorrhage, due to 1C, ruptured congenital aneurysm. The aneurysm goes at the bottom on 1C because it is the true underlying cause.
Perfect. Now let's talk about Part 2 of the certificate. This section is specifically for other significant conditions that contributed to the physiological decline and death, but were absolutely not related to the direct causal sequence you just outlined in Part 1.
And reading through the clinical literature, there seems to be a massive temptation for busy doctors to use Part 2 as a dustbin for every single medical ailment the patient happened to have in their chart. Oh, the patient had osteoarthritis of the knee, throw it in Part 2. They had a mild cataract, throw it in. They had gout 10 years ago, write it down.
I strongly warn junior doctors against that lack of discipline. The epidemiological utility of Part 2 is entirely compromised when doctors lack precision. You should only list conditions in Part 2 that actively contributed to the fatal outcome, even if they didn't cause the primary pathology. For instance, if a patient dies of a severe bacterial pneumonia, which is part 1, but they also suffered from advanced, poorly controlled type 2 diabetes that severely compromised their immune system, the diabetes goes in part 2. It didn't cause the pneumonia, but it made the pneumonia fatal.
That makes perfect sense. And speaking of discipline, the text is adamant that doctors must never record a mere mode of dying in isolation on a certificate.
Yes. You cannot just write heart failure or asphyxia or coma on line 1A and leave the rest blank. Why? Because everyone's heart eventually fails when they die. A mode of dying describes the physiological mechanism of the final moments, but it tells us absolutely nothing about the disease that caused it. A mode of dying must always be qualified by the underlying pathology. If you write heart failure, you must explain why the heart failed. Was it a myocardial infarction? Was it a massive pulmonary embolism? Was it a drug overdose?
Are there any exceptions to this rigid requirement for an underlying cause? What if the patient is simply incredibly old and their body just gives out?
There are a few very specific, highly regulated age exceptions. In the UK, if a patient is over 80 years old and there is a gradual, steady decline with no specific identifiable disease process responsible, it is legally acceptable in certain circumstances to simply record 1A, old age, or frailty. At the absolute other extreme of age, the diagnosis of sudden infant death syndrome, or SIDS, is an acceptable cause of death on a certificate, though the strict multidisciplinary diagnostic criteria for SIDS must be rigorously applied by specialists.
This level of precision might sound to an outsider like bureaucratic pedantry. The patient is dead. Who cares if I put diabetes on line 1B or part 2? But it isn't pedantry. It is a matter of profound public safety. And the textbook explicitly highlights the devastating, horrific consequences when death certification lacks rigorous, independent oversight. It brings up the Shipman effect.
The Shipman case is a dark stain on British medical history, and it single-handedly reshaped forensic certification. Dr. Harold Shipman was a trusted, seemingly beloved general practitioner in a quiet UK town who systematically murdered an estimated 250 of his own elderly patients over a period of decades. He usually killed them by injecting them with massive, lethal doses of diamorphine during routine house calls.
How does a doctor murder 250 people without anyone noticing for years?
He was able to do this because he ruthlessly exploited a massive vulnerability in the certification system at the time. Under the old rules, a single doctor could treat a patient, be the only person present at the death, and then be the sole signatory on the death certificate, citing old age or heart attack. Shipman relied on the fact that society and the legal system implicitly trusted the integrity of the family doctor. There was no requirement for independent scrutiny. He forged medical records after the fact to make it look like the patients had been declining, and he signed the certificates himself. The bodies were often cremated, destroying the evidence.
The public inquiries following Shipman's arrest in 1998, and later inquiries into massive institutional failures at hospital trusts like Mid-Staffordshire, proves beyond a shadow of a doubt that the existing arrangements for death certification were dangerously inadequate. They relied entirely on the unverified integrity of a single individual. This horrific realization led to massive systemic reform, specifically the Coroners and Justice Act of 2009.
And the crowning achievement of that reform was the rollout of the medical examiner system across England and Wales. The medical examiner, or ME, acts as an independent failsafe.
So what does an ME actually do on a day-to-day basis?
An ME is a senior, highly experienced doctor who provides independent scrutiny of all deaths that do not strictly require referral to a coroner. Before a death certificate is officially issued and the body released, the ME reviews the deceased's medical records. They aren't just checking spelling, they are looking for patterns, inconsistencies, or clinical governance concerns. Why did this healthy 40-year-old suddenly die of asthma? Did they get the right medication? They discuss the case directly with the qualified attending practitioner, the QAP, who is the doctor actually filling out the form, to interrogate their clinical reasoning and agree on the precise wording for the certificate.
And crucially, the text notes that the medical examiner interacts directly with the bereaved relatives. They call the family, they explain the cause of death in plain language, and they explicitly ask if the family have any concerns about the care the patient received or the circumstances of the death.
That conversation is vital. Often, a family will mention something that completely changes the clinical picture. Oh, the doctor said he died of a stroke, but he actually fell down the stairs and hit his head 2 days ago. Suddenly, that is no longer a natural death. It is a trauma case, and the ME immediately blocks the certificate and refers the case to the coroner for investigation. It adds a robust layer of transparency and safety that simply didn't exist in Shipman's day.
It is a brilliant system. Finally, let's briefly touch on how the data from these certificates is used globally. Every specific condition a doctor writes on an MCCD is eventually translated by coders into an ICD code, the WHO's International Classification of Diseases.
We are currently in the process of transitioning globally from the ICD-10 revision to the highly advanced ICD-11.
To a tired junior doctor at the end of a long shift, these four-digit alphanumeric codes might seem like abstract, annoying data entry. But historically, this data is the absolute foundation for global public health. Think back to John Snow mapping cholera outbreaks in London in the 1850s using death records. Today, these ICD codes allow epidemiologists to track global health trends in real time. They allow governments to decide where to build hospitals and allocate billions in healthcare resources. They allow researchers to monitor the incidence of cancers or heart disease across different countries and decades. When a doctor writes a disciplined, accurate MCCD, they aren't just filing local paperwork, they're actively generating the vital data that drives global medical research and policy.
That is an excellent summary to begin our wrap-up. The core lesson from Chapter 3 of Simpsons is that death certification is a profound legal act. It carries formal responsibilities that protect the living, provide clarity and closure to grieving families, and safeguard public trust in the entire medical profession. Accurate documentation is paramount. And perhaps the most important takeaway for any practitioner listening, absolute certainty is rare in medicine. If you are uncertain regarding a death, if the circumstances seem slightly off, if the pathology doesn't make logical sense, that uncertainty should always prompt a referral to the coroner or the medical examiner rather than relying on speculation just to get the certificate signed.
It's fundamentally about having humility in the face of the unknown. Before we completely sign off, I want to leave you, the listener, with a final provocative thought to mull over. It's not explicitly mapped out in the textbook, but it is the logical, perhaps terrifying, extension of everything we've discussed today. We talked about how the invention of mechanical ventilation uncoupled cardiac and respiratory rest, forcing the legal system to redefine somatic death around the brainstem. But look at the exponential technological advances happening in critical care right now. We are developing highly advanced xenotransplantation, as we discussed. We have ECMO machines, extracorporeal membrane oxygenation, that can entirely replace the function of both the heart and the lungs, pumping and oxygenating blood outside the body for weeks or even months. We are pouring billions into researching fully artificial mechanical organs and radical cellular preservation techniques. As these technologies continue to advance, will the legal definition of irreversible somatic death eventually require another complete rewrite? At what point does our ability to artificially preserve cellular life blur the line of legal somatic death entirely? If you can theoretically replace every single failing organ with a machine, a bioengineered pig organ, or the lab-grown substitute, when does the biological process of death actually conclude?
A fascinating and incredibly complex question that the next generation of forensic pathologists and legal scholars will undoubtedly have to answer. Now, to ensure the clinical frameworks we built today are properly locked in, let's do a rapid-fire knowledge check. I am going to deliver 5 high-yield, single best answer recall prompts based on the chapter.
I love this. I'll play the role of the medical student. Lay the first one on me, and I'll give the listener a second to think before we reveal the answer.
Prompt 1. A patient's white blood cells are observed moving independently under a microscope. Does this observation legally preclude a diagnosis of somatic death?
Okay, take a second to think. Based on the forensic trap we discussed earlier, my answer is no.
You are correct. The answer is no. White blood cells can move for up to 12 hours post-cardiac arrest. Somatic death relies on the irreversible loss of consciousness and respiration, not the survival of individual resilient cells. If anyone struggled with this, review the section on cellular death. Moving to prompt 2. Under UK guidelines, how long is the patient be continuously observed following cardiorespiratory arrest to confirm the absence of a central pulse, heart sounds, and reflexes before officially declaring death?
Let me give you a moment. I remember the specific physiological reason for this time frame. My answer is 5 minutes.
Spot on. A minimum of 5 minutes is required to rule out autoresuscitation. Review box 3.1 criteria in the text for the complete observational protocol. Prompt 3. A patient in the neurology ward exhibits regular sleep-wake cycles and spontaneous eye-opening, but neurological testing shows a complete absence of any behavioral evidence for self or environmental awareness. What is the correct clinical term for this specific state?
I'll give you a second. The lights are on, but nobody is home. That is a vegetative state.
Correct. Vegetative state, or VS. Remember the distinction. It is wakefulness with entirely absent awareness. Review the section on prolonged disorders of consciousness, prompt 4. On a medical certificate of cause of death, where should a doctor list a condition that contributed to the fatal decline, but was strictly not part of the direct causal sequence leading to the immediate cause of death?
Give it some thought. This is not the first domino. It's the dustbin section, but used responsibly. Part 2.
Correct. Part 2. Part 1 is strictly reserved for the direct causal sequence. Review the section on cause of death determination. Finally, prompt 5. Following the horrific revelations of the shipment inquiry, what specific new role was introduced across England and Wales to provide independent scrutiny of non-coronial deaths?
Take a moment. This is the independent failsafe. The medical examiner.
Precisely, the medical examiner. Review the section on certification and medical examiners.
Excellent work today. We highly encourage you to open your copy of Simpson's Forensic Medicine, dive back into Chapter 3 to review these medical legal foundations, and above all, keep your clinical documentation disciplined and precise. Until next time, stay curious and stay sharp.